Good day, everyone. The Society for Cardiovascular Magnetic Resonance is pleased to present this webinar, Stress CMR Perfusion Cases, Guideline Scenarios, Read with the Experts. My name is Ryan and I will be your host for today's webinar. Please note that today's call is being recorded and all participant lines will be muted during the broadcast. Today's presentation will last up to 60 minutes and include a specific question and answer period. However, you can enter a question for us at any time during today's presentation. You may submit a question by typing it into the Q&A box in the lower center of the window. Then be sure to click on the send button located next to the box. Now it is my pleasure to present Eike Nagel, who will introduce today's speakers. Please go ahead, Eike.
Thank you very much. Welcome everyone for joining us tonight. I learned the first session again to unmute myself. And it's my pleasure to co-moderate today's webinar about a really important topic, myocardial perfusion imaging, especially in the view of the new US guidelines, which place CMR in the forefront of the new guidelines as well. So a lot of action, a lot of changes. And we're moderating this together with Faisal Nabi from Houston Methodist Hospital in Texas, and Chris Kramer from the University of Virginia, and myself from Frankfurt University in Germany. And we'll start with a short how to do perfusion and how to post-process perfusion given by Chris Kramer, who is a cardiologist, head of division at the Department of Cardiology in the University of Virginia, and distinguished professor and past president of SCMR. I think everyone knows him. And I'm happy to open the floor for you, Chris, for your introduction.
Thanks, Eike. So we're going to just take a few minutes here to quickly review how to read and post-process stress perfusion CMR. Much of what I'll tell you is in writing, so you can look it up in Jeanette Schultz-Menger's SCMR Task Force guidelines on how to post-process CMR, and so it's in that document, which was published in JCMR in 2020, and the reference will be on my slides. So here's an example stress perfusion CMR. Atop is a 3 short-axis images at stress, adenosine in this case, and then at the bottom are 3 short-axis images at rest. And if I stop the movie, you would see at the right point, you would see the stress images here at the top, the rest images at the bottom. And I've shared with you the 3 slices, the late gadolinium enhanced imaging slices from the same short axis slices. So this is a complicated case. I just want to take you through it quickly before we go over the details of how to interpret these and what to do. So you can see that at stress, at the base, there's a perfusion defect, certainly in the inferior wall, that is also seen here in the anterolateral and lateral wall at the base. At the mid slice, there's a significant perfusion defect here in the inferior wall, lateral and anterolateral wall. And then at the apex, the lateral and infralateral walls show this perfusion defect. At rest, the apex and mid looks like fairly homogeneous perfusion. At rest, there may be even a rest perfusion defect here in the infraseptum and inferior wall. When you look at the matched late gadolinium enhanced images, what you see is that there's a probably 50% transmural infarct here in the inferior, basal inferior, infralateral. Similarly in the mid inferior and the apex infralateral. So some of the perfusion defect you're seeing is from subendocardial infarct here in the inferior wall, but that's not the case for these anterolateral perfusion defects. There's no infarction and no rest ischemia. So this is a mixed picture with a perfusion defect due to infarction in the inferior wall and a perfusion defect due to ischemia in the anterolateral wall. So this points the importance of looking at matched stress, rest, and late gadolinium enhanced images to come up with your final diagnosis. So let's go through some of the details of how to do it appropriately. And again, all of this is taken from Jeanette Schultz-Menger's task force published in JCMR in 2020. So firstly, as I showed you on the previous slide, you want to display perfusion images and LGE side by side so that you can see if there is a perfusion image, if it's a perfusion defect, is it due to prior infarction or is it purely due to ischemia? You want to adjust the window, contrast, and brightness to optimize the left ventricular myocardial signal. The signal should be black prior to contrast arrival. You want to look at the cine images of the perfusion on a slow image review, because if it goes by too quickly, you can miss the hypoperfusion. So you want to look at it at a very slow speed, or even scroll through the images image by image to really make sure you're not missing a perfusion defect. Because often the perfusion defect may only last 4 or 5 frames before it fills in. So if you look at the images too fast, you may miss a defect. You also want to check that there was a hemodynamic response during the adenosine or regadenosin infusion, and or look for what's called the splenic switch off, which is low signal during the adenosine stress within the spleen. If we go back to the images I showed you, the spleen is over here, and you can see that during adenosine, the splenic signal is lost, and then you see it perfused normally with contrast later. Compare that to the rest images where the signal in the spleen is more uniform and normal, and not there's no splenic turnoff. So that's an important marker of the adequacy of the vasodilator stress, the so-called splenic switch off. So many labs look only at stress images and don't do rest images. I will say that our lab still continues to do rest imaging, because sometimes it can help delineate artifacts, but there are many labs who do stress imaging only, and as well as late gadolinium enhancement. So how do we define an inducible perfusion defect? First of all, it occurs first when contrast arrives within the LV myocardium. If you see a defect before there's contrast in the LV myocardium, that's an artifact. It should persist beyond peak myocardial enhancement and for several cycles, several RR intervals. It is generally more than 2 pixels wide. If you see a defect that's only 1 pixel wide, you need to be concerned that that's a dark rim artifact, which I'll mention more on a subsequent slide. Perfusion defects are most prominent in the subendocardium and may become less dense towards the subepicardium. If you see a perfusion defect in the subepicardium alone, that's likely not due to coronary artery disease. It may be due to another cause of fibrosis in the subepicardium, but it's generally not a perfusion defect. The perfusion defect should be present at stress and not at rest. If it is present at both, you need to look at the LGE images to see if it's an infarct. If it's not an infarct, you have to be concerned that there may be an artifact causing that. And it should conform to a coronary territory. You typically use the AHA 16 or 17 segment model. 17 segment only if you acquire long axis perfusion imaging. To do the analysis, again, using that model. So lastly, a couple words about artifacts. The most common is what's called a dark rim or dark band artifact. It's most prominent when contrast arrives in the LV blood pool, so before contrast arrives in the myocardium. The signal may be reduced compared to baseline. You can draw a region of interest in it if that helps. It's generally very transient and before the peak myocardial enhancement. It occurs predominantly in the phase encoding direction. And the most important point, it's narrower than a perfusion defect. If you think back to the perfusion defects that I showed you on the perfusion images, they're broad and go well into the midwall. And in some cases, we're nearly transmural. The dark rim artifact is very narrow, only on the subendocardial surface, and it's generally 1 pixel wide. What is it due to? Generally motion and Gibbs ringing, two causes of the dark rim artifact. It's present often at stress and rest, although it generally is more prominent at stress because it's due to motion there, because of the heart rate increase and the patient may be having symptoms, having a little more trouble breath holding during the vasodilator stress. You're more likely to see the dark rim artifact, again, due to heart rate effects and motion. Here's an example of a dark rim artifact, very narrow band here along the septum. And generally you can see it at stress and at rest here at the bottom. Here seen here again, 1 pixel wide, right at the subendocardial surface. Remember, a perfusion defect is going to go well into the mid-wall. And well, that I'll end and thank you for your attention, and we'll move on to the next speaker. One other slide, just a couple pitfalls. Multivessel disease, a balanced ischemia is rare. So generally you won't, that's not a problem like it is in nuclear. We're not talking about quantitative perfusion analysis today, but if it is performed, you generally will demonstrate greater extent of ischemic myocardium. And microvascular disease may lead to global subendocardial reduced perfusion. And this is another case where quantitative analysis may be useful. And with that, I'll end and stop my share. I think the next speaker, am I to introduce the next speaker, Ika? Oh, Faisal, you're.
I'd be happy.
Yeah, okay, great. Thank you.
Hi, good afternoon, everyone. Real pleasure to be here. Thank you for the opportunity to SCMR. Real pleasure to introduce the next speaker, a good friend of most of us. Dr. Parwani is a multimodality imager and assistant professor at Loma Linda. Very important also is she's also an early career chair in SCMR. And we'll begin our cases with, I believe, 2 cases today.
Can you see my slide?
Yes.
Perfect. Thank you, Faisal, for that kind introduction. Thank you, SCMR and the organizer of this conference to inviting me to speak on this on this topic. So I'll be sharing 2 cases today. I'm early career chair for SCMR and real pleasure to be here today. So my first case is a patient with chest pain and intermediate risk of coronary artery disease. So she's a 56-year-old African-American female. She has past medical history of hypertension. She's also pre-diabetic with a hemoglobin A1C of 6.2. She's obese with BMI of 35. And in fact, there have been issues getting her echocardiographic images because of her BMI, in spite of giving her contrast. The regional wall motion abnormalities or the endocardium was not well visualized on echocardiogram. She has mixed hyperlipidemia with LDL of 106, and she presents to clinic with the chest pain that is in the center of the chest, but mostly present at rest. So she has normal EKG because of her BMI. She has some knee arthritis and a limited functional capacity. And as I mentioned, she has very difficult echo images. So if we look at the present guidelines that were just released, this patient falls into that intermediate risk category. And if we look further in intermediate risk category, the stress CMR falls into that 1B category for intermediate to high risk patients with stable chest pain and no CAD. Stress CMR can be performed. So a stress CMR was performed for this patient. So let me see if I can make everything play. Okay, perfect. Okay, so as you see, on the top are the stress images, on the bottom are the rest images. And these are the basal, mid, and apical slices. And as you can see, both as on rest as well as stress, there's homogeneous uptake of the contrast into the myocardium without any differentiating features or any defect in the endocardium, etc., consistent with the inducible ischemia. Going further, she had a pretty normal cine imaging with normal biventricular size. I think you guys able to see the movies. Faisal, are you able to see it?
It's not moving currently. It tends to be a little bit stochastic.
Yeah, it's, I think, stuck. Nonetheless, she did not have any late gadolinium enhancement as well on her delayed enhancement images. I'm having difficulty forwarding the slides here. Let me see if I can just stop share and share again. No. Brian, do you mind sharing my slides? So that first case was a case of a completely normal perfusion in a patient with chest pain and intermediate probability for coronary artery disease. Brian, are you there? Can you share my slides?
Sure, just 1 second.
Thank you. Perfect. So if you can just forward it to case 2. Keep going. Keep going. Yeah. So as I said, this was a patient with normal stress CMR, no previous infarct, and normal LV ejection fraction. No further investigations were performed. Next slide, please. Okay, so case 2 is a 60-year-old male. He has past medical history of hypertension, hyperlipidemia. His hemoglobin A1C is 6.9, so he has milder version of diabetes. He's a smoker. He smokes 3 cigarettes per day for 30 years. And he also has family history with father with myocardial infarction at age 59, although his father was also a smoker. He presents to our clinic with exertional substernal chest pain associated with shortness of breath and diaphoresis. Next slide. So if we look at the present guidelines again, stable chest pain, this patient falls into in the high risk category given his comorbidities, his family history, as well as smoking status, and stress CMR again falls into the class 1 indication for this patient. Next slide. Yeah. So if you just let it all play, Ryan, if you hit next one more time. So there's a bit of a delay on my side, but I hope that everyone can appreciate the stress images on top and the rest on the bottom. And as you can see, compared to the last patient who had a homogeneous uptake in the myocardium, this patient has this defect in the apex right here. Also in the mid wall, as well as in the base. So I know this can be a bit overwhelming while presenting in the webinar and looking at 6 slides together. So if we go next slide, please, Ryan. And then let it play. Hit next again. Yeah, so I hope that everyone can now appreciate the defect that are seen. So as we can see, there is multiple regions that are involved in this patient from basal, mid to apex. and compared to rest, it's quite abnormal response. As Dr. Kramer suggested, the dark rim artifact typically would disappear within 6 RR interval, while this defect, it stays throughout this perfusion. So next slide, please. And if you let it play, hit one more time. So this patient also had normal LV and RV function with no late gadolinium enhancement. Next, please. On cardiac catheterization, as we had expected from that multiple region involvement, he had significant triple vessel disease, and given his comorbidities, including diabetes, was referred for bypass surgery. Next slide, please. So this is the example of multivessel ischemia, no myocardial scar, and the viability was present. So 3 goals achieved at once. Next slide, please. So that's my last slide. Please don't forget to submit evaluation for this program. Thank you.
Thank you, Purvi. That was terrific. And we'll now move to Dr. Chetan Shenoy, who's from the University of Minnesota. He's an associate professor of medicine there, cardiologist and clinical researcher in CMR, and he will present our next series of cases. Dr. Shenoy.
Can I share the screen, please? Thank you, Chris, for the kind introduction. Okay.
Perfect.
So this is the third case. So this is a 44-year-old male who presented with more than a year of history of substernal chest pain. And this was classic by history. It was worse with exertion and associated with dyspnea. He did not really have any prior CAD or CAD risk factors. And his EKG showed normal sinus rhythm with first degree AV block, a PR interval of 210 milliseconds. There were really no ST or T wave changes. So the primary care physician obtained a stress echocardiogram, and these are still images. On top, rest, and at the bottom are stress images. And what we can see is the cavity is larger on the stress images. So the patient had multiple stress-induced wall motion abnormalities and transient ischemic dilation. And this was suggestive of severe and extensive CAD. So these are the 4-chamber and 2-chamber views, and these are the parasternal long axis and short axis views. All are very concerning for severe CAD. So he went straight from the echo lab to the cath lab, and interestingly, and to our surprise, he did not really have any obstructive CAD. And so from here, the patient was sent for a stress CMR to figure out what exactly was going on. And these are his cine images. So on top are the short axis images, base, mid, and apex, the 4-chamber, 3-chamber, and the 2-chamber long axis images. And we saw a mild increase in wall thickness with the maximal wall thickness of 1.4 centimeters, but there were no real resting wall motion abnormalities. And we did stress perfusion, and we again saw multiple perfusion defects in multiple coronary territories, and they actually did not conform to any specific coronary artery territory. And here are the still images from the stress perfusion images. As you can see, this is involving the inferior and some of the lateral wall. Here it's involving the septum. And here it appears to involve the septum and the inferior wall. And so knowing the coronary anatomy, again, this did not quite fit into ischemic coronary artery disease. And the answer lay in the late gadolinium enhancement images. And again, these are short axis images, base, mid, and apex, and the 4, 3, and 2-chamber images. And what we see is diffuse subendocardial enhancement, which is involving pretty much all the segments. And this pattern of enhancement is seen in only two non-ischemic cardiomyopathies, and one is cardiac amyloidosis, and the second is eosinophilic myocarditis. And given his history of symptoms for more than a year, this was most likely cardiac amyloidosis. So he was sent back to the cath lab for an endomyocardial biopsy. And this is just a cartoon showing that we can use the pattern of enhancement to diagnose the cause of the cardiomyopathy, particularly non-ischemic cardiomyopathy. And what we saw in this case was a global subendocardial hyperenhancement, and the first possibility is cardiac amyloidosis. And the endomyocardial biopsy confirmed this, and the subtype was AL amyloidosis. You can read more about this case. We published this in Circulation in 2018. And the conclusion is that when another non-invasive test and an invasive coronary angiography are discordant, then stress CMR can help solve the puzzle. This is obviously a scenario that is not really in the guidelines. Separately, stress CMR can also diagnose non-ischemic cardiomyopathies that may present with chest pain or symptoms that are suggestive of coronary artery disease. My next case, this is a 52-year-old male truck driver. He presented with atypical chest pain. This was a few years ago. Now we would call this as possibly cardiac chest pain. He did not have any known coronary artery disease. He had a few cardiac risk factors, including hypertension and previous history of smoking. He was obese with a weight of 425 pounds, and his height was 6'2". The BMI was 55. On EKG, during this presentation, he was found to be in atrial fibrillation. This was a new diagnosis for him. He was rate controlled at 84 beats per minute, and he did not really have any ST or T wave abnormalities. He was, because of his chest pain, he was sent for an exercise stress test, and he was found to be in atrial fibrillation with rates in the hundreds at the exercise stress test, and therefore it was not done. He was then started on rate control medication, and the stress test was switched to a regadenoson nuclear stress test. So this was a patient who was seen at one of our community hospitals. And because of his weight, a 2-day protocol was done for the nuclear stress test. And these are the images from the nuclear stress test. And as you can see, the images are quite suboptimal. So the interpretation was that this was a technically difficult study with suboptimal image quality, significant soft tissue attenuation. And there were a few abnormalities that were noted. There was a fixed defect in the infraseptal wall with associated mild peri-infarct ischemia. There was also a moderate ischemia in the anteroseptal and apical wall. So all of this was suggestive of disease in the left anterior descending coronary artery. His EF was read as 39%. However, the accuracy was questioned because he was in atrial fibrillation and the quality of the study was technically difficult. And so at this point, he was sent to our university hospital for further management of likely LAD disease. Based on the quality of the nuclear stress test, we decided to perform a stress CMR. We considered a coronary CTA, however, that was not the optimal test because of his obesity, which would lead to lower image quality, higher radiation. He was also in atrial fibrillation, which is not the ideal situation for a coronary CTA. Invasive coronary angiogram was considered, but obesity is associated with higher radiation dose to the patients and the physicians. In one paper, the dose was 2.2 times for BMI of more than 40 compared to BMI of less than 25. So we ordered a stress CMR. The patient was able to fit into the CMR scanner. Our bore diameter is 70 centimeters, which translates to a maximal circumference of 86 inches. And the weight limit is typically 550 pounds. He was in atrial fibrillation during the study with the heart rate in the 80s, but we were still able to obtain optimal image quality. These are the cine images. You can see there are some cardiac artifacts. However, we can see that the cardiac function is normal. There are no real regional wall motion abnormalities. This is the stress perfusion images, base, mid, and apex. We don't really see any perfusion defects here. So this was completely normal. And this is a frame from each of these, again, showing the absence of any perfusion defects. And then we were able to obtain optimal late gadolinium enhancement images as well, without any evidence of scar or MI. And so the conclusion was that EF was normal at 54%. There was no ischemia, no scar, and we did not do any further testing. So you may ask, how do we know that this was the right decision if we did not do a coronary angiogram? Well, this study was done in December of 2015, and we have follow-up of 6 years. The patient is alive, is free of MI and all other cardiac events, and he is being followed on an annual basis for his atrial fibrillation. So the conclusion is that stress CMR is a great option for obese patients. These are some of the papers, single center papers from the Brigham, from Germany, from France, and we also have a multi-center paper from the SPINS registry, all showing that stress CMR is feasible, diagnostic, and carries high prognostic value in obese patients. Thank you.
Thank you, Chetan. Very nice cases. Exciting to see where MR can help, and also that it really works in very obese patients with atrial fibrillation. So thank you for that. The next speaker is Bobby Hedari from the University of Calgary, Stephen Cardiac Imaging Center, and he is Associate Professor of Cardiology and obviously doing cardiac MR, at least as part of his job.
Thank you so much for that introduction, Dr. Nagel, and to SCMR for inviting me, and of course to our illustrious moderators. So I'm going to present two cases. The first case is a patient with chest pain and an expected diagnosis. So this was a 41-year-old female fashion designer with no prior cardiac history, but a positive maternal family history of premature atherosclerosis, who presented to a cardiologist with stable CCS class 2 chest pain symptoms that were fairly typical for angina. The cardiologist actually organized the cardiac CTA in 2014, and we see here the results of the CTA. We can see here for the left anterior descending artery, there was no significant atherosclerosis. However, there was moderate mixed plaque within the mid-right coronary artery and the mid-left circumflex artery. I apologize for some of these annotations. The CTA also demonstrated a congenital anomaly with a separate ostium for the LAD and the left circumflex with no left main. Based on the CTA results, the cardiologist initiated the patient on goal-directed medical therapy. Invasive cardiac catheterization was offered, but the patient refused invasive evaluation. And actually, she did quite well for approximately 6 years with stable CCS class 1 to 2 symptoms. But unfortunately, she developed recurrent symptoms at rest, which prompted her presentation to the emergency room. And she was actually admitted for unstable angina as she had negative cardiac biomarkers or acute electrocardiographic changes. She was referred for invasive cardiac catheterization. And we see the images here, which will hopefully play. And so very interestingly, what the results demonstrated was that there was actually distal collateralization of the LAD to the posterior descending artery. Indeed, there was a mid-occlusion of the right coronary artery with distal collateralization actually filling the distal vessel. There was quite severe mid-LAD disease, and there was actually downstream disease within the obtuse marginals as well. However, at the time of the cardiac catheterization, there was also concern by the angiographer in regards to the ostial LAD portion of the coronary artery. And in order to further assess that, an intravascular ultrasound was actually attempted. And when the IVUS catheter was inserted, the patient developed severe chest pain. There was diffuse ST depression on the monitor, and the patient became hypotensive. So the IVUS was aborted, and the angiographer presumed, excuse me, ostial LAD disease. And so the patient was referred for coronary artery bypass grafting, but unfortunately the patient refused due to cosmetic concerns regarding sternotomy. And the surgeons were also concerned about the potential lima anastomosing to the LAD becoming atretic if there was significant competitive flow within the LAD. And so the patient was referred for stress CMR to better evaluate the ischemic burden. So the patient underwent a standard adenosine protocol, as Dr. Kramer outlined in the first talk. And we see the stress images on the top and the rest images on the bottom. And if we stop the images, we can see that there were quite significant perfusion abnormalities from the base, mid, and apical portions of the inferior wall, as well as the lateral wall, but that the anterior and anterior septal segments were relatively free of perfusion defects. Likewise, the patient had normal ventricular function, and there was no subendocardial late gadolinium enhancement, as Dr. Sinoy discussed earlier, to suggest a prior infarct. And so the stress CMR demonstrated no inducible ischemia within the normal distribution of the left anterior descending artery, but there was severe inducible ischemia within both the left circumflex and right coronary arteries, with a viability of the entire LV and preserved LV global systolic function. The subsequent CTA was also repeated to confirm that there was no ostial LAD disease, and as such, the patient was actually referred for percutaneous coronary intervention of the RCA and the left circumflex coronary arteries. Interestingly, in retrospect, the angiographer felt that the IVUS-induced periprocedural ischemia was likely due to loss of the LAD collaterals to the RCA, as opposed to ostial LAD disease, as had been presumed initially. And so the patient underwent percutaneous coronary intervention with very good results. The patient's chest pain symptoms completely resolved post-percutaneous coronary intervention. She developed CCS class 1 functional status, and a follow-up stress CMR at 1 year demonstrated completely normal myocardial perfusion. I think this case is a good example of a very important trial that was discussed in the earlier sessions, the MR-informed trial conducted by Dr. Nagel and colleagues, which actually compared a stress CMR to an invasive FFR strategy for the evaluation of stable chest pain patients. And although there were no significant differences for the 1 year primary composite major adverse cardiovascular events, there was substantially lower normal invasive cardiac catheterizations in the stress CMR strategy. And in addition, there was substantially lower use of invasive therapies, which can be very important for the patients. Excuse me, I just wanted to highlight that for certain patients, invasive assessment of coronary physiology may be challenging. That does include patients with ostial coronary lesions, patients with coronary stenoses in series, if there are highly tortuous coronary vessels, or distal collateralization of occluded coronary vessels. At times, for these patients, invasive FFR can be a challenging technique to evaluate these patients. So the next case that I'll describe is a patient with chest pain and cardiomyopathy. This was a 44-year-old female nurse who developed new onset acute decompensated heart failure and was admitted under the cardiology service for further evaluation. Unfortunately, she did develop sustained ventricular tachycardia during the initial phases of her hospitalization that did require chemical cardioversion. She had minimal chest pain throughout, but she did have quite a significant resting sinus tachycardia. She was an ex-smoker, but had quit 2 years ago, and she had no other coronary risk factors or known pre-existing disease. So on the basis of her presentation, she was diuresed and she was referred for both nuclear perfusion imaging and echocardiography. So here we see her nuclear perfusion imaging with stress imaging at the top and rest imaging at the bottom. This was a vasodilator SPECT study. And the SPECT study demonstrated normal myocardial perfusion, but a reduced LVF of 40%. A subsequent echocardiogram confirmed the reduced global LV function graded at 40 to 45%, as well as no significant valvular heart disease. And so she was referred to cardiac MRI to evaluate for potential etiologies of infiltrative cardiomyopathy. But her MR protocol was actually changed to a stress evaluation due to the concern of balanced ischemia that, again, Dr. Kramer had raised in the initial talk. She was actually quite tachycardic during her stress study. I think her heart rate reached above 120. But despite that, although there is a fair degree of cardiac motion, we were still able to procure diagnostic images demonstrating perfusion abnormalities in multiple coronary territories. These were not present at rest, and there was evidence of subendocardial late gadolinium enhancement throughout the basal, mid, and apical inferior segments, suggesting a prior PDA territory or posterior descending artery territory infarction. So the CMR demonstrated mildly reduced LV systolic function, no evidence of infiltrative cardiomyopathy, severe stress perfusion abnormalities consistent with multivessel disease, and non-transmural MI within the normal distribution of the RCA, as well as a largely viable left ventricle. So based on these results, the patient was referred for invasive cardiac catheterization. And we can see here the images demonstrating quite severe disease. So there was very severe distal left main disease. Again, we see collateralization of the distal PDA from the left circumflex artery. And actually the RCA was completely proximally occluded. So this was unprotected left main disease. Based on these results, the patient was referred for coronary bypass grafting, which did occur with a LITA to the LAD, a RITA to the right posterior descending artery, and a saphenous vein graft to her obtuse marginal. Post-surgery, the patient was discharged and returned to normal functional status within 3 months. She had no further chest pain or shortness of breath. And at 1 year follow-up, she was completely asymptomatic with normalization of her global left ventricular function on echocardiography. And so again, I think this is a very good, this case is a very good example of the concept of balanced ischemia by nuclear perfusion imaging. There's a very nice paper by Dr. Vogel, Clausen and colleagues from the NIH. And this was a small but very elegant study where they examined 31 patients presenting to the emergency department with chest pain and normal cardiac enzymes. These patients received both a nuclear perfusion imaging and an MRI. And what they demonstrated is that in a substantial proportion, as high as 30%, the MR revealed ischemia despite a normal nuclear perfusion study. And they found that risk factors for this phenomenon included diabetes and hypertension. Thank you so much.
Super, thank you very much, all presenters, for their excellent presentations, excellent cases, wide variety of things. May I remind all participants to submit their questions through the chat so we can discuss them. We have a couple of them coming in already. And the first one actually asked whether you can have a perfusion defect only in the basal slice, but then not in the mid or apical slice, or wouldn't you expect a perfusion defect, which is in the basal slice, to also show in the mid and apex? And the question actually came via Dr. Pravani's talk, so maybe I'll give it to her first, and then maybe, yeah, let's just do that first, and then we'll move on from there. You're still muted.
I see that Dr. Kramer already tackled that, but I think that you can see it, as he said, with the basal inferior segment. Of course, it is rare to see just basal, but I think that it's possible.
So, and why would you, if you have a basal coronary artery stenosis, somewhere close to proximal coronary artery stenosis, why would you not have a mid or apical perfusion defect?
I think it depends on if a branch vessel is involved proximally, particularly, it can be, it can be present just in the basal segment and not present in the mid and the apical segment.
Mm-hmm. I think something which really nicely highlighted that was the case also from Dr. Hadari with the large amount of collateralizations, where you have normal perfusion in all the more mid and apical areas, but some severely abnormal perfusion in the base. And you also see that when you have myocardial infarction, which can very well be in the base or base and mid, but not involving the apex due to collateralization. Exactly. There are a few more questions. Maybe I'll give that one back to Chris, actually. Is there a clear rule on dark rim artifact Gibbs ring? Can you really say it's never more than one voxel? Is it is there an absolute way to discriminate the two, or is it difficult sometimes?
No, sometimes it is difficult. In general, it's 1 pixel wide, a very narrow band. Occasionally it can look a little broader than that, but it generally is, often the entire circumference of the LV, although it can be commonly in the septum, more commonly than other locations in my experience. But generally only 1 pixel wide. It'll be there before peak perfusion in the myocardium, and it can be a difficult differential though. But I think with more experience, you get used to seeing these dark rim artifacts.
Mm. Well, what we actually do is we don't blacken the images completely before the contrast agent comes. We keep them slightly grayish. So then if it gets darker with the contrast agent arrival, we know this can't be a perfusion defect, because a perfusion defect wouldn't get darker. It would just not get brighter. So we don't completely blacken the images. We always keep a little bit of gray value before the first pass comes in.
There's a question that just came through, which maybe you might want to answer, which patients are not good candidates for stress perfusion CMR?
You see, I don't have an immediate fast answer to that. So I personally don't like the ones with devices. Not that it's impossible to do the devices, it's just the effort is very high. The effort of getting someone to help getting the patient in, of looking after the patient while the ICD is switched off, then the artifacts are slightly more. Even though we can reduce the artifacts, they're still slightly more. And then there are alternative techniques for those, which may be easier. So that's one group where I tend to say, if there's another technique, why don't we use the easier approach for the whole system? Second is those with severely reduced ejection fraction. If ejection fraction is really low, the contrast agent delivery is not the greatest, so the first pass is really slow. And if you have a really slow first pass and a thin, not so much pumping myocardium, which sort of sluggishly goes along, you just don't get great perfusion images. I still tend to do them in those patients because the more important question often is hibernating myocardium, how much viable tissue is there? And that very often answers the question, because if the question is, should the patient get revascularized, not revascularized, bypass surgery, not bypass surgery, and you say, this area of the myocardium is completely dead, there's no remaining viability, it actually answers the question of more than the perfusion. But those would be the ones where I'm not so keen on doing the perfusion scanning.
Yeah, case in point to underscore with your last example, we had a case about a month ago, presented new onset heart failure, no prior chest pain. He had a huge infrabasal LV aneurysm, clearly ischemic, and the rest of his EF was in the teens, and the rest of his myocardium was thin, and it was a false negative perfusion study, part because the walls were thin and the contrast got there so slowly that he had it turned out to have left main and multivessel disease. So this was a case where I think we were hampered by the wall thinning and the slow contrast uptake. So that will be the kind of case where you can see a false negative stress perfusion study. Another group of patients that I have trouble with in our lab is AFib with rapid ventricular response, right? They're a group that we tend to avoid. I don't know about others on the webinar.
I have a question to Dr. Chenoy. In your first case, the patient with amyloid, would you have made that diagnosis if you had not seen the coronary arteries first, just based on the perfusion and the late enhancement, or would you have been maybe going in a different direction?
No, so the late gadolinium enhancement was very obviously in a non-ischemic pattern. And so it involved practically 15 of the 17 segments. And while we can see multivessel CAD, the LGE is never a uniform subendocardial involving all the coronary territories. So even in patients with multivessel CAD, they can have varying transmurality of the LGE, and it's never uniform as in this case. And so the differential essentially is cardiac amyloid or eosinophilic myocarditis.
Yep.
So the thing that I did not mention in the presentation is why did we see the very obvious ischemia or perfusion defects? And so in cardiac amyloidosis, there is extensive microvascular disease due to perivascular amyloid deposition. And so it is, in fact, true ischemia. It's just not due to epicardial obstructive coronary artery disease.
Mm-hmm. Which brings me back to the point which we had discussed, balanced ischemia versus triple vessel disease. And maybe from all three presenters, how do you deal with balanced ischemia? Is there such a thing as balanced ischemia? How do you deal with severe perfusion defects? How do you go about those cases?
So I can start. So everything in ischemia interpretation is a comparison to normal. So we are looking at abnormal or a perfusion defect compared to normal myocardium. And so for balanced ischemia to occur, all the segments should be equally ischemic, which is never the case. But on nuclear imaging, because of the lack of resolution, you may not see the relative differences in the perfusion. Whereas on stress CMR, thankfully, because of the improved resolution, we are able to see the differences in the ischemia between the coronary artery territories. And so we may see one territory having transmural ischemia, another territory may have subendocardial ischemia. And almost always, even with multivessel disease, we see some myocardium which is not ischemic. So there may be extensive involvement, but it never involves all the segments uniformly in exactly the same way. Therefore, I don't think there is the issue of balanced ischemia on stress CMR at all.
Would the other two presenters agree?
I would say that in addition to what Chetan suggested, there is also, you also have cine imaging, which are way, much better. On nuclear, there is LVEF that is assessed on nuclear SPECT or PET, but often it is difficult given the size of the image and stuff. And along with that, you have LGE to decide, and to see the tissue characterization. So you can differentiate all that he mentioned from subendocardium to transmural infarct at a much more confidence if you put everything together. And that's why we have been saying that it's the one-stop shop. It gives you quite a bit of details at once.
Just like to make, I agree with all the points, and I really endorse what Dr. Kramer said at the outset, which is to also have rest perfusion imaging. I just find that having rest perfusion to help rule out dark rim artifact is extremely useful.
We don't do rest perfusion at all, but that's maybe our local specialty. Just one thing I wanted to add to triple vessel disease versus microvascular disease. What we tend to do is we also look at the very early wash in of the contrast agent when it just arrives in the epicardium. And it arrives at the epicardium in all three vessels at the same time, or maybe one heartbeat later at the RCA than the other territories. Then you know that the epicardial perfusion per se is kind of similar. Whereas in multivessel disease, they arrive at different time points because also the contrast agent delivery is already disturbed, and you can see that. So the temporal plus the spatial resolution really make the difference to not miss multivessel disease and to see microvascular disease.
And I was just going to add another thing that we've seen in our lab is we've had a couple of cases where, let's say you have a very, very tight stenosis, and of course, your stress perfusion will be off, but even where you may see a similar defect in your rest perfusion images. And I think that's where wall motion again comes very important there, because you should technically, if it's such a tight lesion, be able to pick that up on your cine images. And I think the other very important thing is really, we have all, as Purvi mentioned, we have all these different components. Especially with multivessel disease, you will sometimes see the cavity get bigger or EF will drop at peak stress. It can be subtle, but we have to train our eyes to look for it.
So I think we are slowly coming to an end. I would like to first thank everyone. Great cases, great questions, good discussion. We see that CMR perfusion is really strong in multiple scenarios, in the difficult patients and the ones which had previous coronary artery imaging by CT or invasively, patients who may have something else. And that's something I really want to highlight. A 70-year-old male with typical chest pain and 2 risk factors has a pretest likelihood of around 50%. So in most of our patients, it's about finding a reason for chest pain, and it's not automatically coronary artery disease. And this is something I really want to highlight. We should not, as good doctors, just stop saying it's not the coronaries, your chest pain is something else, but we don't care. We should find out what is the reason for the chest pain. And MR is really perfectly suited to do that because it answers all these other issues where it's not the coronaries. And we have seen a few cases today which very nicely show that. We also very nicely showed that it works in patients which are massively overweight, patients who have massive amount of risk factors, patients with atrial fibrillation, and it finds a diagnosis very often. We still do discuss these artifacts, but we discussed them much less than 5 years ago or 10 years ago. At that time, we would have kind of gone about that most of the time because they have been coming much less. The sequences are much more robust. We all know much more what we're doing. I think we really should push this technique as something which really helps us to understand the patient. Thank you very much.
Thank you.
Thank you.
All right. Thank you very much, everyone. And with that, we must conclude today's webinar. You will soon receive an email from the SCMR with links to the evaluation survey for this webinar. To register for any of our upcoming webinars or meetings, or to view recordings of previous webinars, please visit scmr.org. Thank you for your participation in today's webinar. We hope to see you here again soon. That concludes today's program. You may now disconnect.